Okay, good afternoon, colleagues. Welcome to the second interdisciplinary lecture that we are hosting today. We are very pleased today that we're going to have a surgeon presenting to us, and I'm sure Dr. Annika will introduce her and will say that it is very appropriate functional neurosurgery, which becomes really important in not only in neurology, but also in psychiatry. So we're looking forward to the talk, Dr. Shezi. Over to you, Basal. Thanks.
Yes, good afternoon, colleagues. Welcome. Thank you, Professor Teliza, and welcome everybody to the second series. It gives me a great pleasure to introduce my colleague, Dr. Nomusa Shezi, who's a specialist neurosurgeon here at Albert Luthuli and a lecturer in the Department of, in the discipline of neurosurgery at UKZN. Dr. Shezi's got particular interest in functional neurosurgery, and she has done some extensive training in this and spent time with various experts as well in this field locally. And she's just going to give us a glimpse as well into what functional neurosurgery is all about and its applications, particularly here at Albert Luthuli and internationally, and how as well it relates to the discipline of psychiatry. So without further ado, I think I'll hand over the reins to you, Dr. Shezi. Thank you, and welcome everybody.
Thank you. Thank you, Dr. Annika. Can everyone see my screen?
Yes.
Okay. Thank you for this opportunity to discuss a topic that I think is very integral to improving quality of life of our patients. So I will be talking on movement disorder therapy. So the surgical therapy of movement disorders in Inkosi Albert Luthuli has been my experience in this unit. So firstly, I'll just take us through a history, an introduction of functional neurosurgery, as well as brain stimulation and neuromodulation. Brief anatomy. I know that movement anatomy tends to be quite intense, and registrars tend to shy away from it, but it is important in our understanding of our intervention and understanding our targets. And then the movement disorders that do qualify for surgical intervention more specifically. And then leading up to surgery, the multidisciplinary team that is integral, the surgery prep, day off and post-op, and what all of that entails for our patients and the team that is involved. And then looking forward as well. So movement, functional neurosurgery is not just only linked to movement disorders, but a myriad of neuropsychiatric conditions that affect us all. So I will start with, how do I get this one? Okay. So I'll start off first with just tactic and functional neurosurgery. What is that? So functional neurosurgery is a subspecialty of neurosurgery that deals with using structural and functional imaging to identify and target discrete areas of the nervous system with the aim of modulating outcome, neurological outcome. Deep brain stimulation utilizes functional surgery to neuromodulate using electrical currency in those targeted areas with specified outcomes that are proven over time with research related to the areas that are being targeted. There is decades, almost centuries, intersection between neuroscientists and psychiatry in relation to neuromodulation using electricity, electrical current, and then in the last 25, 30 years, using directed therapy with deep brain stimulation. Okay. So in terms of the electrical current through time, it takes us all the way back to 46 AD, where a physician by the name of S. Lago was the first to describe in his journal, he was a physician to a Roman emperor, that an electric eel applied to the head could somehow improve headaches. Obviously, we've gone a long way from there, but this just speaks to the inquiring minds, physicians, surgeons in trying to identify the brain as a center of stimulation affecting, at that time, headaches, and as we go on through history, affecting movement as well. In the 19th century, in 1809, G. Aldini, in the more darker versions of our history, using the decapitated heads of prisoners, actually described that applying electrical current to the cortex could stimulate facial movement. And so at that point was the beginnings of us understanding the link between the electrical current and affectation of movement. In 1887, Victor Halsey, one of quite a well-known British surgeon, gave us a very important landmark of describing the topography of the brain, of trying to understand the link between particular areas and structures within the brain and areas of the remainder of the body and how they are linked. And that work was further completed by Penfield in the 1950s, also giving us a detailed topography of the brain and allowing us to not wildly aim into the brain, but have specific areas that we know affect specific areas of the body. In 1938, Ugo Seletti is credited with being the first or being one of the few to stimulate the brain for psychosis. This coincides with the electrocurrent stimulation that was occurring for schizophrenia as well as epilepsy, but it started as early as 1930, even though the full anatomy and intersection was not fully understood, but they did have good outcomes for patients with epilepsy and psychosis and schizophrenia with electric current stimulation. And in the 1950s, again, brain stimulation was identified for treating chronic pain by Markles and Walls. They also started the research, which is still carrying on now in terms of treating chronic pain with electrical stimulation and finding targeted areas. So where I come in as a surgeon, obviously in the last 30 years, but going further, so deep brain stimulation involves stimulating the deep structures of the brain with the aim of modulating movement. So the first discovery that there were certain parts of the brain in the basal ganglia that actually affected a patient with tremor was accidentally discovered by Cooper in the 1950s and 60s. And he, after performing surgery and inadvertently injuring the deep-seated vessel that resulted in a basal ganglia stroke, when the patient woke up, the patient's tremor had actually improved. And subsequently, he then did a few case studies, about 25 to 50, where he had deliberately occluded those vessels with varying results, but more or less targeting the area that the basal ganglia and the thalamus was involved in the propagation of essential tremors. The stereotactic frame was developed in 1949, which is obviously important in us directing the therapy as opposed to the previous general electrical stimulation of the brain. And ablative surgeries with the stereotactic frames were then employed. Those ablative surgeries were important in our learning curve. They involved permanent ablation of deep structures of the brain. So the good part was that symptoms would improve. The side effect that was unacceptable and right now has fallen out of favor was that if there was a side effect, it was irreversible. The damage to those central structures was permanent. In the 1970s, as I'm sure we're all aware, levodopa was then employed and came in vogue, rightfully so, as treatment for Parkinson's disease more specifically. And as a result of that, the research into movement disorder took a dip in the scientific world, as levodopa was a non-invasive, quite effective drug that was then treating quite a significant pathology of Parkinson's disease, not curing it, but definitely improving the patient's quality of life. But in the background, we still had neurosurgeons and neuroscientists who were still investigating. So we have Delgado, a Spanish neuroscientist, who is accredited with implanting probes. So he was one of the first people to implant probes to treat schizophrenia and epilepsy in 1986. And that is the more better work that he was accredited for, and not the other less ethical activities that he used to partake in trying to perform mind control with those implants put in. I mentioned Bektereva, who is a Russian neuroscientist, the lady on the left, because though her work was not widely acknowledged, she was a Russian neuroscientist who is actually the first to insert chronic depth stimulation for treatment of movement disorders. But unfortunately, because her work was published in Russian and only in the Russian literature, it wasn't widely dispersed, and so she's often been overlooked in the history of deep brain stimulation. So this is just important for us to understand the burst of activity in terms of surgery for movement disorders has really been in the last 30 years, since the 1990s. Earlier on, the work, as I said, had declined, more so because levodopa had been developed. There were no proper neuroimaging, as MRI were not available. So surgery was really a hit and miss for most of the time. But from 1990, deep brain stimulation was being targeted more in monkeys for Parkinson's disease. In 1997, the FDA in the USA actually approved deep brain stimulation for essential tremor, which then started sparking an upward in use of deep brain stimulation for movement disorders. In 2002, we had the approval for deep brain stimulation for Parkinson's. We've had 2003 for dystonia. So those are the three really important indications for movement disorders: dystonia, essential tremor, and Parkinson's disease, that were approved in the early 2000s. And then in 2009, we had FDA approving deep brain stimulation for OCD. In 2018, we had approval for deep brain stimulation for epilepsy. And we have extensive work in terms of addictive personality disorders as well. So that work is still going on, and there are centers who are performing them, even though we haven't reached a stage where they've had FDA approval. So deep brain stimulation, as I said, is permanently implantation of electrodes within the brain with a pulse generator in the form of a battery. And this allows us a way of intervening of neuromodulation that is both controllable, as in we can adjust the frequency of our modulation. We can reverse it if the patient has unacceptable side effects, and because we can also remove it if we feel it is not effective, unlike the previous interventions, which were more permanent regardless of whether the side effects were acceptable or not. So the primary use for deep brain stimulation in terms of movement disorders is Parkinson's disease, and our target areas are the subthalamic nucleus and the globus pallidus internus. For essential tremor, it's the VIM, which is in thalamus, and for dystonia, it's a GPI. It has also been approved, as I've said, for epilepsy and OCD, and chronic pain and depression, and others are still being under research. So this is just a video to illustrate exactly what occurs within the patient. There is a probe that is implanted. This is the battery that is put either on the right or left upper chest on the patient, with a lead that is connected into the deep structures of the brain, into the basal ganglia, and then, as per programming with the surgeon and the neurologist being involved, stimulation is provided to execute effect. So as far as deep brain stimulation is concerned, it is a young field, but it is very mature. I say young because in terms of the ethical approval and the FDA approvals, they've been starting from 1997 all the way to the latest being 2018, 2019 for some of the other therapies. But since the 1990s, there have been more than 180,000 cases of DBS being done worldwide. And there's been quite a lot of research with randomized control studies, which is where our gold standard is in medicine in terms of deep brain stimulation versus best medical therapy, especially for Parkinson's disease. So though we do not have 50 or 60 years of utilizing this procedure, it is by no means novel therapy or a therapy that is still experimental. So as I said, the randomized control studies are numerous. They've proven that deep brain stimulation improves the survival of patients with Parkinson's. It improves the quality of life of patients. And more importantly, where medical therapy is no longer effective or the side effects are unacceptable, deep brain stimulation can also be used as a rescue therapy in order to intervene and improve the patient's life. As far as South Africa is concerned, our first case of deep brain stimulation that's recorded was done in 2000 by Dr. Melville, a neurosurgeon, who is still in his 80s practicing in Cape Town, who've had the pleasure of working under him for a while. And multiple private centers are performing deep brain stimulation, and way too few state hospitals are providing the service. So most of the deep brain stimulation procedures in our country offered in private and not necessarily in a government institution. In Albert Luthuli, I was involved in the first case, still training at the time in 2012, that was done, that took a total of about 16 hours. But since 2018, we've decreased the time to less than 8 hours with the patient being awake, and also working on developing a team, because as I will carry on explaining to you, deep brain stimulation, it is not a rogue surgeon operating by themselves, but the team is much more essential to the patient's good outcome. We've also had a lot of work by one of our colleagues, an esteemed colleague that I've had the pleasure of working with, Dr. Ahmed, who is a neurologist in Albert Luthuli, who has published a lot on Parkinson's disease in KZN. And one of the studies that she has published has shown that the prevalence of Parkinson's disease is increasing in our country and in our province. And this obviously means that the patients that qualify for interventions are also increasing. In 2017, there was a stakeholder meeting of neurosurgeons and neurophysiologists and neuropsychologists and psychiatrists who met, mostly in private, as they were the ones who were performing these procedures, as I've said, but they met to create a guideline for deep brain stimulation in our South African setting. So the fact that we are a low middle income country does not preclude our patients from getting these procedures, as it has been proven to be worthwhile and cost effective and improving the quality of life of our patients as a standard of care intervention. So I make a case for deep brain stimulation in KZN. As I said, we have more than enough international evidence. We might not have enough in South Africa because of the lack of cases that have been done, but there is enough international studies to show that deep brain stimulation improves the motor control of the patient and the quality of life. And that in some cases, deep brain stimulation is equivocal to best medical therapy, and definitely is an indication when levodopa has run its course and the side effects of the drug are quite significant and the patient cannot tolerate the drug. In terms of cost effectiveness, again, deep brain stimulation is not a cheap procedure. Per patient, probe and the full equipment can go up to 120,000 after discount from industry. So it is quite costly, but having looked at, especially the stakeholders meeting that published in 2017, they looked at the cost of patients with Parkinson's disease, progression of disease, recurrent admissions and complications, poor quality of life, and also side effects from the drug, comparing all of the cost of treating that patient and a DBS. The DBS was actually equivocal. Putting probes was not mostly to the state, to the patient as well. So there is proven benefits, 60% reduction in dyskinesia, which is a significant side effects that can happen with levodopa on patients, but reduction in tremor, up to 80% rigidity and bradykinesia, and then a 40 to 60% in reduction in medication requirements of the patient. And this is also important because the higher the dose the patient is requiring, the higher the chances of side effects from the medication and the medication no longer being effective. So we go on to target sites. As I've mentioned, the target sites for movement disorders is different ones for the other neuropsychiatric conditions, but specifically for movement, the VIN in the thalamus has been identified as the structure for treating tremors. The subthalamic nucleus is the one that's a standard of care for Parkinson's disease and also OCD to a lesser extent. And in the Parkinson's disease, it's important for reduction of rigidity and bradykinesia. And then the posterior hypothalamus is also being worked and investigated for treating cluster headaches as well, as a target for deep brain stimulation probe insertion. So just a short array into the anatomy. That's important for us to know that the basal ganglia is an important structure in terms of our motor circuits and smooth motor function of our patients. So obviously our cerebral cortex is where all movement is initiated, but the basal ganglia is where movement is modulated in order for patients' movement to be smooth and not to have excessive or markedly reduced movement as required. So the basal ganglia is comprised of what is called the corpus striatum, as well as the lenticular nucleus. So on this video on the side, if you can just follow with me, this is the cortex, and the structures are centrally located paraventricular. So the structure that you can see are the ventricles that are on either side, the lateral ventricles that are on either side of these structures that are deep-seated. The pale blue structure is the caudate nucleus, which forms part of the corpus striatum, the caudate nucleus, as well as the putamen. They form part of the corpus striatum. And then the lenticular nucleus, which is comprised of, again, the putamen, the globus pallidus internus and externus, as well as the substantia nigra and the subthalamic nucleus and the thalamus. All of these structures within the basal ganglia are important for controlling movement, planning and programming of movement, and then the cognitive control, obviously, that initiates from the cortex. So as I said, you have the input and the output. So the input is directly connected to the cortex, and that is formed from cortex to the neostriatum, which is formed by the putamen, the globus pallidus externus and internus, the substantia nigra, more specifically the pars reticular of the substantia nigra, the subthalamic nucleus, and the thalamus. And then the output is from the thalamus to the motor area, which then will modulate the movement as modulated by the input. So when we are dealing with movement disorders, we treat these structures as much as they are separate structures, but we treat them as circuits that are communicating using neurotransmitters and electrical currents in different circuits that are interlinked. So you have the cognitive loop, the motor loop, the limbic loop, and the oculomotor loop, which all form part of the basal ganglia circuit. So the cognitive loop is important for cognition, thinking process and memory, and that is why patients who have Parkinson's disease where the basal ganglia is affected will eventually, unfortunately, have a dementia and suffer from and cognitive decline. The motor loop, which is obviously where we are intervening as the surgeons, which is what we can affect, that is more linked in with your subthalamic nucleus or substantia nigra, as well as your globus pallidus. Your limbic loop, which is connected to your nucleus accumbens, which is part of your basal ganglia, that is important for your emotions, your smiling, your aggressive responses. That's also closely linked, and that is why patients with Parkinson's will have what we call facial masking due to the affectation of this nucleus. And then the ocular motor loop, that's concerned with voluntary eye movements. This is also important when we are intervening, as I will discuss later on as one of the side effects. If you are not monitoring closely of deep brain stimulation, so the disorders of the basal ganglia that are pertinent to us, you have hyperkinetic and hypokinetic disorders. So the hypokinetic disorders is lesions that affect the direct pathway, and the important one is obviously Parkinson's disease. And the hypokinetic that is also FDA approved is dystonia. Unfortunately, all the other ones at this point in time have not been proven There is not enough research to justify them being approved as a standard of care or intervention. So Huntington's disease, athetosis, there is some research into tardive dyskinesia, but nothing that would warrant us at this point utilizing the procedure. So I just wanted to go on terms of our significant movement disorder that affects us, this Parkinson's disease. It is recognized as the second most common neurodegenerative disorder in the world. The prevalence increases with age, and as I said, the research that we have done in Dr. Ahmed has done in KZN, the frequency of Parkinson's disease, even in our population, is just as high. So to have a setting where the patients have access to medical therapy, but once the medical therapy, either the patient does not respond or unfortunately the side effects are quite significant, it is equally vital that we are able to offer the patient further therapy that is standard of care on the international standard. So again, we have guidelines for Parkinson's disease, not so much for essential tremor and dystonia, but they can be translated as they're all in line with just the multidisciplinary team that is important in intervening and treating these patients. So I just wanted to also clarify, when it comes to Parkinson's disease, deep brain stimulation unfortunately does not treat the other pathologies that occur due to the disease. So it cannot reverse dementia or cognitive decline. It cannot reverse speech problems. It cannot reverse most of the gait problems. But where it is significantly improving the quality of life of the patient it is with the tremor, the rigidity, and the akinesia. And that is important, especially when counseling patients and families, that they have insight that deep brain stimulation, like levodopa, is not curative of Parkinson's disease, but at least stays the disease and can allow for delayed deterioration of the patient. So as I said, levodopa is still a viable and very important part of treating Parkinson's diseased patients. Will first and foremost be treated and intervened by the neurologist, who in their workup of the patient, either by the patient having requiring increased doses or no longer responding to levodopa, will make the judgment that the patient can benefit from Parkinson's, from deep brain stimulation. Clearly, the surgeon's intervention is only at that point and cannot be the first point of interaction for the patient, because we've identified a non-invasive and quite effective medication that can respond. But as part of the holistic care of the patient, then the neurologist with the neurosurgeon can make the best decision for the patient. So who is the ideal candidate for deep brain stimulation as far as Parkinson's and movement disorders are concerned? Selection, it's important to assess patient suitability, dopamine responsiveness, and then neurocognitive evaluation. So this is where the multidisciplinary team is important. So the age has to be between 40 and 70. The guidelines previously were 5 to 10 years of having been diagnosed and being treated with levodopa, but they've been revised in 2018 that you can have a much closer age, as in less than 4 years of treatment. If the patient's initial response is good and they've got predominantly motor symptoms, you can offer the patient deep brain stimulation. If they've got severe dyskinesia as a side effect of levodopa, deep brain stimulation is the ideal candidate procedure for that patient. If the patient has to be cognitively intact, and then setting realistic expectations, as I've said, the counseling for the patient is quite critical for the patient to understand that it is not curative. So it is a staying of the disease and preventing a deterioration of the disease, but it definitely does not cure and remove Parkinson's disease from the patient. The neurocognitive evaluation is extremely essential. Dementia as a pathology is an exclusion criteria for deep brain stimulation, as targets that are for movement disorders, if you do put a probe and the patient has already got dementia, it can accelerate the disease. Severe depression is also an exclusion criteria for deep brain stimulation. So I've mentioned to you that there is research for deep brain stimulation for depression, but the targets are quite different. So for movement disorders, it is an exclusion criteria, and the neuropsychiatric input and intervention is important. If they can improve the depression of the patient, then you might be able to offer the deep brain stimulation. But the dementia is an absolute, if the patient has already got established dementia, then that is an exclusion criteria. And then obviously, I go back to, this is a multidisciplinary team involvement. 30% of surgery failures across the globe is usually due to incorrect patient selection and lack of team cohesion. So the integral members are the neurologist, which obviously in Albert Lutuli, we are happy to have had someone who's got more than a decade of looking after Parkinson's patient, the neurosurgeon, the neuropsychologist, and the psychiatrist in order to evaluate for early onset dementia, in order to evaluate the patient for depression, which will obviously influence the outcome of the procedure. Neuroanesthesia is also an important member of this team. In other international centers, deep brain stimulation is performed both awake or asleep, depending on surgeon preference. But from my experience, I'm still doing awake surgery. And so a neuroanesthetic team that is able to manage a patient awake for the duration of the procedure is absolutely essential for the success of the operation. Neuroradiologist, the particular sequences and being able to perform them, that's also an integral part of planning, pre-operative planning. The neurophysiologist, as I will mention later on in terms of our microelectrode recording and stimulation and identifying where we are intra-operative. So the neurophysiologist is also essential to the team. And then obviously a dedicated nursing team. This procedure, especially in the early phases, is quite labor intensive. The workflow is essential to go smoothly in order to allay the patient's anxiety, especially if they're awake. So having a team that is familiar with the procedure, that is efficient, will allow for no unnecessary delay and the best outcome for the patient. So as I said, our peri-operative work includes the indications, as I've mentioned them, and then making sure that the exclusion factors are excluded, because that will affect our outcome, more importantly, before we even touch the patient. Pre-anesthetic assessment as well, and also assessing anxiety levels of the patient. Sometimes it's simple as counseling the patient and explaining to them, but if the patient is severely anxious, having the procedure being done awake would be a contraindication, as the patient blood pressure will start climbing and increasing the risk of bleeding intraoperative. And then obviously the planning pre-operative and MRI, and then awake craniotomy and regional block. So as I said, the awake anesthesia, that is with the competency of the anesthetic team and their familiarity. The importance of this is obviously you need to be able to wake the patient up quickly in order to be able to do assessments, and also be able to intervene if the patient should start struggling. The process, as I said, the first one I participated in was quite long, about 16 hours, and that can be extremely exhausting for the patient. But with the more recent cases that I've been doing, they've been about 6 hours. The patient can cope with that level of time if they're awake, but you just need to be able to manage their pain and their comfort level. So the anesthetic team is quite essential to that. The imaging that is important is MRI targeting, which is done before the surgery is done. There's a protocolized sequence that allows us to target the structures that we will be aiming for when we are doing the procedure. You need at least a 1.5 Tesla field, which obviously in Albert Lutuli was not something I had to work for, because we already had targeted Tesla MRI that provides us with good quality imaging. You also need a CT brain the day of surgery, which is important for putting in the frame and the stereotactic frame. All of this is in planning our trajectory and ensuring that we land in the right space. So when we are targeting these deep structures, how we ensure that we land up in the right place. It is not guesswork. You have direct and indirect method of planning the target. So the direct method, which is what we use, especially the more advanced our MRI imagings are, is visualizing the anatomical structures. As you can see here, we're able to even reproduce them in the 3D formats in different colors, so we can identify the structures and plan exactly where we'd like to place our probe. And then the navigation will be able to calculate where our entry point would be. The direct visualization as well with the different imaging allows us to also look at the vascular structures and plan to avoid any vessels, arteries and veins, as well as if possible, the ventricles as well, because that can, if you land in the ventricles or go through the ventricles, it can also cause drifting of your probe, which can affect where you eventually land. The indirect method of planning the targeting, that was mostly employed pre-90s when the MRI quality was not as good in order to identify the targets and plan for it. So I use both methods, both direct and indirect, to plan the trajectory. So the indirect method is where we use pre-known atlas coordinates that were measured from more than 500 cadavers being cut up and basically creating a GPS coordinate of where we expect the thalamus, the globus pallidus, the subthalamic nucleus to be, and those coordinates are then translated to the patient. So obviously you can clearly see that the problem is that patients don't read textbooks. So when you have coordinates that say the subthalamus nucleus is supposed to be 12, 3, and 3, the patient might be off depending on atrophy, depending on the patient's make. So we employ both in order to just reinforce both the direct and the indirect and reinforce our localization. This frame, after doing the MRI planning, which is done the day before, which doesn't require the patient, it's just the patient's image, on the day of the procedure, as early as possible, about 7:30, we would have had a discussion with the radiologist that will be coming in to do a CT scan, which we use with the frame being put into the patient. So in other more advanced nations, they have got the frameless stereotactic radiosurgery up there yet, so we're still utilizing the frame. And the frame is essentially, you have to use a regional block in order to be able to put the frame and secure it on the scalp, as well as local anesthesia that should be able to last you for the duration of the procedure, because that frame is put in and only removed once the procedure is done. So once we've taken the patient to CT scan, so this is the frame that would have been used to give us the coordinates that are then fused and merged with the MRI to give us the entry points of our frame. We then put in the rest of the frame on the patient, and the patient is secured on the table. Unfortunately, I hadn't gotten permission to take a video, so I only took a picture of this patient in which we had them with the Lexel frame that we use here, and patient then secured. You have your images to the one side that have pre-planned the day before, and then on the other side, which you can't see off frame, you've got the coordinates and the frame that you're constantly checking to ensure that your stereotaxy, as you would with radiosurgery, is in the right direction. So I mentioned that, so our verification involves the MRI, it involves the CT scan, and then we also use intra-operative micro recording and macrostimulation. So over the years, the research has found that the structures within the brain have different stimulation recorded can be picked up and identified. So even as we move through the deep brain structures, we are able to identify when we reach the thalamus, the zona incerta, the subthalamic nucleus, the substantia nigra, and if we go deeper, the patient will have clinical manifestations. So this helps us as well in ensuring that we are landing in the subthalamic nucleus, not in the zona incerta or the thalamus, which sometimes the patient can have clinically transient improvement, but the neuro micro recording and stimulation will allow us to ensure that the actual recording is of the subthalamic nucleus and not the thalamus and not the zona incerta. And then obviously the neurologist, even intra-op, as I said, I do my procedures at this point for the foreseeable future awake. So the neurologist's job, which is critical as well, is in examining the patients and ensuring that as we are stimulating and moving the probe and increasing the frequency of our stimulation, the optimal clinical effects are reached. So decreasing the tremor, the rigidity, and the bradykinesia without the side effects that are not wanted. So the side effects is contralateral muscle contraction as well as eye deviation, which can sometimes either indicate the probe is too deep, or it can indicate that the frequency is too high. So we can then adjust using the clinical assessment. So this is just a picture to show you the dramatic changes that the patient actually experiences as the stimulation is applied. You can see the tremor suddenly improve and reduce quite markedly. And this obviously makes a big difference in terms of the patient's quality of life and ability to function once we are out of the operation period, and then they are going home and we're activating the program. So ultimately, from my procedures, I use a C-arm to do the final check, as that's the only intraoperative form of verification that I have, radiological that I have. I do not have an MRI or CT scan available in our unit as yet. So using the direct and indirect method, using the micro recording and stimulation and the clinical, we then finally confirm that the lead is placed in the right place using the C-arm, which should give us that the probe should lie within the airs of the target frame, which is pre-planned. So if that goes according to plan, then we are safe to move out of the patient. This procedure is obviously labor intensive, so you want to go in and do it right the first time and not have to come back for further surgery. So as I said, freehand versus intra-op verification is a conversation, not so much in centers where intraoperative MRI and CT scan is available, but definitely for my settings, awake surgery provides a better outcome for the patients. So the clinical response for deep brain stimulation that we are looking for is that, one, we must be accurate with our placement, and two, patient must have a good response. So that is the aim and that is the goal. With intraoperative MRI, you can have the patient asleep and the accuracy can be absolutely confirmed and the response is only really checked afterwards. But because the accuracy is verifiable with an MRI, the patient should have a good response, because a poor response will either mean the wrong diagnosis or there's something wrong with the programming itself, because the patient would have been pre-planned for that target. If you are not accurate, you can get lucky and land in the right direction and having to increase the frequency of your stimulation. But obviously we are not trying to work with luck when we're dealing with motor and electrical stimulation and neuromodulation. So from areas where MRI and CT scan intraoperative is not available, up until experience is sufficient, using an awake patient and having the micro electrode recording, as well as the neurologist examining the patient, those ones are the for me at this time are the best for giving us good results for the patient, both clinical and being accurate with the placement. So after that has been done, you can then place the impulse generator, the battery, in a sense, either in the right or left upper chest, and that has a probe that goes almost for the surgeons like a shunt that goes subcutaneously from the probe all the way down to the generator. Some centers can defer this procedure and do it at a later stage, a week later. I just do it all at the same time. So after the awake portion, where the patient has been awake and it has been examined and I'm happy with the placement, then we would put the patient to sleep And then obviously, because we have to tunnel, and that will be too painful for the patient, and then connect the plug so that the patient only needs to go to theater once. I think the benefits of it is obviously our theater time is limited, so we want to bring patients for 2 separate procedures. Deep brain stimulation is not without its side effects. That would be the goal and the dream, but it does have side effects, but they are manageable, and the most significant ones are quite rare and do not occur frequently. So intracerebral bleeding is one that is quite important to look out for, especially for patients who are awake. As I mentioned, that the patient is anxious or tired, or the neuro anesthetic is not familiar, and the blood pressures are running high. You do have a risk as you are moving this probe up and down, and because when you first start with the stimulation, you have to put the stimulation probe in before you put in the final probe. So all of those manipulations of the blood pressures uncontrolled can result in the patient having a bleed, which obviously will be disastrous. Infection of the lead or the wire is also another complication, and that's mostly linked to the duration of the procedure. So the more frequent the procedures and the experience of the surgeon, and the less the duration of the procedure, and then the less the risk of infection. So it is a significant infection, complication, but it is one that in any center should initially, with the learning curve, increase but decrease over time. And then you can have some transient complications, which you expect with the lesioning effect to be there, but should improve, and that should be numbness and hemihypoesthesia, limbic side effects. The patients can be emotional procedure. As I said, the basal circuit that's close by is the nucleus accumbens, so the patient can have some limbic side effects that you should expect, but they should be transient if you are in the right position and haven't moved your probe in the wrong place. Post-operatively, all the patients then, we start working them towards the road to programming, and that's where the neurologist experience is quite integral and important. We do not turn the probe on immediately. We wait at least for 2 weeks. In that 2 weeks, the patient might have some symptom improvement. That's just from the lesioning of the procedure and the stimulation that is done. But the actual permanent effects will be altered once we start the programming. And obviously the patient should still be on medication. As I said, deep brain stimulation is not curative, same as levodopa, but there is a reduction in the requirements of the medication. So the neurologist involvement is still quite integral, because then they will make it a determination whether there is a 60% reduction or even more reduction in requirements of medication as we are adjusting the program. So looking forward, in terms of deep brain stimulation, I think the takeaway message that I want you to take is that it is an established method of treating movement disorders. It is not novel. The limitations is obviously in our country, in our province. Most of it has been in private and not so much offered to our patients in state who rightfully deserve it and would benefit from it. Neuromodulation is the future in neuroscience. So this goes beyond movement disorders. As I said, epilepsy has been FDA approved. Identifying the anterior thalamic nucleus, the hippocampus and subthalamic nucleus as targets that has helped greatly in treating patients with epilepsy, as opposed to epilepsy surgery, where you sometimes have to remove quite a significant portion of the patient's cortex. Obsessive compulsive disorder, the ventral part of the anterior limb of the internal capsule has been identified, as well as the subthalamic nucleus has been identified as targets as well. And OCD has also received FDA approval since 2009. Depression, severe depression is also being investigated, but as I said, the targets are different from movement disorders. So the targets for depression is your anterior cingulate cortex, which is obviously part of your limbic circuit, your inferior thalamus, your nucleus accumbens. So that those targets are still being researched. Some centers are performing deep brain stimulation for depression, but there is not enough literature and data to offer it at this point as a standard of care. Chronic pain, also addiction, Alzheimer's, there's been research since the early 2000s, which would obviously be significant for patients, at least preventing acute deterioration in their memory. So the target being the fornix or the entorhinal cortex. All this is to say, we should not be shying away from deep brain stimulation, but leaning into the science, because probably in the next 10 to 20 years, deep brain stimulation is going to be the most offered and should be the most offered procedure for patients when they have these conditions that will have minimum side effects. Important part is that it is reversible. If necessary, you can remove the procedure, you can adjust it and make it patient specific and not provide a global treatment. And obviously from my side, thanks to my team, it's still a work in progress. I completed 5 years since doing these procedures. Dr. Ahmed has been quite integral as being a neurologist for the last decade in Albert Luthuli and seeing the patients with Parkinson's and dystonia and being able to refer the patients that have that we've worked up and operated on. Dr. Slavitt is also in that picture. He's a private neurosurgeon in Pretoria, who I had to employ his expertise and decades of experience, also so that when doing this case, I can inspire confidence. The better outcomes that you have earlier on, the more people are willing to do the procedure that is novel to them, but definitely not novel internationally. And obviously we're still working with having a neuropsychologist and neuropsychiatrist as part of the team. In Albert Luthuli, unfortunately, we don't have psychiatric support, but we have had a psychologist who works with our patients. But all of these are important in ensuring that our patients are worked up appropriately and the correct patient is selected for the procedure so that the outcomes are beneficial. Thank you.
Wow, thank you, Dr. Shezi. That was an excellent presentation. I enjoyed every minute of it. Now I'll just open up the floor for some questions. We still have a bit of time. It's 5 to 12. And before we jump into questions, I think Professor THELIMIT, I'll read this comment and question that is posted. Any scope for you, Dr. Shezi? Any scope for PPP? Perhaps patients with resources from private practice come to Albert Luthuli for income generation of our hospitals. What's your comment on that?
I'm actually quite open to that. Like I said, most of the deep brain stimulation is being performed in private. I had to go to Dr. Melville in Cape Town so that I could learn and learn under him, precisely because in states we don't have a lot. Patients that are willing to be operated in private, in public, and their medical aid, they are more than welcome. I've had private neurosurgeons come in to do cases with me because they also just want the experience and they don't have the expertise on the private sector from their side here in Durban. So it's definitely not a closed loop. The community is small, so no one is fussy about keeping the patients. If they are willing, I would be more than willing to do those procedures.
Thank you, Dr. Shezi. Any questions and comments from the audience? Well, I think people are thinking about their questions. What about patients with Parkinson's disease and depression? Is DBS suitable for these patients, and does it assist with their depression? What's your thoughts on that?
So as I said, severe depression is a contraindication for deep brain stimulation for Parkinson's disease, because of the location of your nucleus accumbens close by in your globus pallidus internus or your subthalamic nucleus. But depression itself as a different entity, it is still being researched for deep brain stimulation. So as I said, your anterior cingulate cortex, your inferior thalamus are possible targets. But when they coexist, we have to treat the depression first. If it's severe and not reversible with medical and neuropsychiatric intervention, then unfortunately we cannot offer the patient because we can actually worsen their condition.
Thank you. Dr. Harichan Prasad.
Thanks very much. Thanks for an excellent presentation, Dr. Shezi. Keep up the amazing work. Just a quick one regarding, previously there was a lot of work done for ablative surgery, So DBS, I mean, this is amazing work because it's got much more advantages compared to lesioning and ablative surgery. Maybe you can comment on that?
Yes, so I think if you can still remember my long look into history, ablative surgery was really in vogue in the 1950s and 60s, and a lot of factors were influencing that, right? So our imaging wasn't up to scratch, and the experience internationally was more in the VIM, the thalamus, and so surgeons were more, osteotaxy was more linked with ablative surgery. It's good in terms of if you target the right area, you will have improvement. But the problem is obviously the irreversibility. So once you've damaged that area, even if you have significant side effects, the patient is then left with that. Unlike deep brain stimulation, even within the last decade, Medtronic, who is one of the leading companies, and I think Boston Scientific are working on even directional probes that we can implant. So even as you put in your probe, it doesn't necessarily stimulate in a circular format. In terms of the effect, you can direct it anterior, posterior, medially, depending on where your probe is, and that increases your chances of a good outcome. So it is a procedure that was done, but I think at this point, you'd be hard to justify that just because we cannot reverse the side effects if they are unwarranted. But I think obviously for maybe countries where, or centers where there is no neurosurgeon or a person who's comfortable to do DBS, they can still explore it, but understanding the complications.
Thanks very much. I think the future is here with us, and you can only move forward with that and take it to the next level. Yeah, keep up the excellent work. Thank you.
Thank you. Thank you, Dr. Arichan Prasad. We've reached, I think, 1 o'clock now, and thank you, Dr. Shezi, for such an excellent presentation, and I thank the audience for attending. Just before we close, I'd like Professor THELIMIT, if you'd like to say something before we close. I know we're running out of time now.
Yeah, no, thank you so much, Dr. Shezi. It was excellent. I really enjoyed the presentation. I think it'll be good to have more discussions about maybe the type of patients that you would prefer, and maybe also a little bit of a case series discussion about the outcomes of those patients that you have had DBS on. But thank you so much. Basal, all I wanted to say is that next month we are having a fantastic talk on dementia, which I think is also a very interdisciplinary kind of topic. Hopefully psychiatrists, neurologists, physicians, and others will join us for next month. Thank you so much.
Excellent. Okay, thank you, everyone. Thank you for joining in, and enjoy your weekend. And thank you, Dr. Shezi, once again. Bye-bye.
Thank you.